single-payer universal health care is a human right and would improve the lives of everyone in the US. But we acknowledge that on its own, it won't necessarily solve the problems of ableism, racism, sexism, homophobia, etc., that currently exist in our medical system. I want to acknowledge the role that capitalism plays in creating disability through adverse working conditions, war and violence, environmental injustice, and the lack of accountability of the medical industrial complex. But we also acknowledge that disability is a fact of life, not a tragedy, and the insights of people with disabilities are critical to improving our healthcare system. We're holding this summit to listen to the concerns of the disability justice community so that single-payer initiatives, both state by state and national, can incorporate solutions to those concerns. We believe that if we work together with all people in the community, we can achieve an equitable healthcare system for all. We plan to write up the issues that we discuss here and advocate with state-based single-payer groups that are proposing legislation. Our moderator for the panel is Alex Dietrich. She is a neurodivergent queer woman of 20th century working class immigrant descent. She got her start in social justice and equity in her high school years and is now a civil service worker and union member who aims to bridge the generational gap in healthcare reform with an emphasis on disability justice. Michelle Hamilton, a board member of One Pair States and Healthcare for All Pennsylvania, may also be asking follow-up questions, as well as Chuck and I. So we'll go over to Alex now.
Thank you so much, Pat. I'm so happy to be here. The last few times that I participated in these summits have been truly life-changing. So I'm really excited to get working with these panelists, introduce them, and then start to have a conversation. The way I usually do this, we keep this natural conversational. I will introduce them with everything that I know, let them speak to who they are, what they believe, have a short conversation if time permits, and then afterward we'll have about 30 minutes for us to have a Q&A. So we will start with Kim Jackson. Dr. Jackson has a Bachelor of Science in Biomedical Engineering from Rutgers University and a Doctor of Osteopathic Medicine from the University of Medicine and Dentistry from New Jersey. After medical school, Dr. Jackson specialized in family medicine and practiced in Pueblo until 2012, when a progressive neurologic illness forced her to leave practice. She moved to Denver in 2013 and took Colorado Cross Disability Coalition's basic advocacy class in 2014. Using her experience as a physician and a person with a disability, she helped to create a training on disability for medical providers and has been to over a dozen clinics around the state to facilitate training sessions. Dr. Jackson has testified at the state capitol on a number of bills important to the disability community. She serves on 2 committees for Colorado Medicaid, the Pharmacy and Therapeutics Committee, and the State Medical Assistance and Services Advisory Council, to which she was appointed by Governor Hickenlooper in 2015. So Dr. Jackson, so nice to have you on. Can we bring Dr. Jackson to the forefront?
Thank you for that introduction, Alex. I hope everyone can hear me. Pardon me. That bio is a little bit old. I've done some other things since then, and I'm actually now the chair of the Colorado Prescription Drug Affordability Advisory Council. And we were created by Colorado legislature about 4 years ago now, and working with the Colorado Prescription Drug Affordability Board to try to find solutions for unaffordable prescription pricing in Colorado. And recently, too, I joined a steering committee that has been organized by the National Association of State Directors of Developmental Disability Services on a project called the Link Center. But it's a steering committee of people such as myself that live with intellectual and/or developmental disabilities and also co-occurring mental illness. And so, as Alex mentioned, I'm a physician. I was practicing family medicine in Southern Colorado until 2012. And I have a number of conditions I've been diagnosed with since then, but my health started going downhill. I started having trouble remembering words and realized I wasn't safe to practice anymore. And since then, have started working in the disability community in Colorado and using my experience as a physician and a patient to help others out. And so my main diagnoses now are Ehlers-Danlos syndrome, which is a genetic condition, but I'm also hard of hearing and wear hearing aids. I'm autistic and have an autism spectrum disorder. I have pretty severe post-traumatic stress disorder. And I use a power wheelchair for mobility. As you see, I have a neck brace on chronically. I need more surgery on my neck, but my condition causes instability where my neck is basically just falling apart. And my gut no longer functions. And so I'm completely dependent on IVs to survive. And I have been for 6 years now. And the reason I mention all of those conditions is because most people with chronic illnesses, people often will deal with one major condition that they're focused on. And as physicians, we tend to think of, okay, we're going to treat this condition. We're going to help this person with this condition. But when you have as many as I do, and you end up with multiple complex disabilities, all of a sudden it goes out the window because you have to treat everything together. And with that too, doing prescription drug work especially, there have been a lot of policies that have been created to try to make sure that the right people are getting the right doses of medications, and to try to exclude medications that are more risky. And being a person who has extremely rare conditions, a lot of those medications that might end up on those lists as being too risky are the only treatment options available to me. For example, with my gut not working, I also have severe allergies. I can't use topical medications on my skin either. And so I'm very limited in treatment options. And so thinking about single payer healthcare, I've been in support of single payer healthcare since I started med school many, many moons ago, and before that even. Because I agree, it's a social justice principle. We're one of the only developed quote unquote nations in the world that doesn't offer healthcare as a right to its citizens and to the people living within its borders. And I think universal healthcare can be a great way to make sure that we're all getting the care that we need. And with that though, for people like me that have multiple complex conditions that need extremely rare treatments, I might not fit into the policy that we create for single payer healthcare. Examples being, again, the medications that I can't take. I have attendant care to help me live independently at home, and I need to continue that. But I have to be able to hire my own workers because working with agencies with all my allergies, it's very difficult to control who comes in. And so exceptions to the rules are extremely important to me, and I'm often the exception to the rules. And so with single payer healthcare, with having only one payer available, one set of rules and guidelines around what's covered available, that's my option, whatever is there. There aren't other insurance plans I can go to necessarily, or other ways I can access what I need. And so I need to be able to say, okay, I understand that this is why we are trying to do treatment in this one way with most people, but I don't fit into that. So we need to do this. And it shouldn't be a huge fight every single time I need something that's slightly different than the standard of care because of my conditions. And so, I mean, I know a lot of people with multiple conditions that have the same issue. And so I just really want to bring to the forefront with disabilities, for those of us with multiple complex disabilities that also have chronic health conditions that frequently access the healthcare system, we need to be able to have exceptions available so that we can get the services, we can get the care that we need, we can get the equipment we need without a fight. Realizing that, I mean, we talk about patient-centered medicine, and unfortunately it's turning into patient-centered means you put the patient in the middle, you surround them with the system, and the patient just gets completely overwhelmed because it all goes on them at once. Where as opposed to designing a system that works with each patient. But exception policies are a big part of that, and realizing that everybody is different. People respond to different medications. People need different treatments. And that's just how we are. And so how can we make sure that the right people are getting the treatments that they need to be comfortable, to live their life the way that they want to live their life in whatever bounds they might have. And really to get the care that they need and to have that equity and that justice available for all of us with disabilities. And then briefly, the only other thing I just wanted to call to the forefront is we also need to really look at the system in terms of a whole, as well as what do we do when we discharge patients and we send them away. Some of the work that I'm doing with this steering committee, we have members that have gone in the emergency room in mental health crises or with mental health conditions. And even though they're in a very serious state and they're at risk of harming themselves, the ER says, we don't know what to do with you. We can't admit you here. We don't know where to send you. So you're just gonna have to go back home. Or people getting discharged from the hospital with mental illness and especially developmental and intellectual disabilities and mental illness together, and not having an appropriate place to discharge to. So, oh, well, we're just going to discharge them to the homeless shelter they were living in when they started having these issues in the first place. And so I just wanted to call that to the forefront because I'm absolutely appalled that that is happening, that people, I mean, for myself, a lot of my trauma comes from the medical care I've received, and not necessarily bad experiences, but just the whole process of going through them. But with everything I've been through, if I go to the emergency room, it's me saying, I really need help. I need help right now. And if they say, well, we really can't do anything for you, even though we agree you need help, you should probably just go home. I don't know what I would do, but it would make it a lot harder to go back again the next time something like that happens. And so I just wanted to call that as well to the forefront, that in a single payer system, we need to think too, not just about the hospital, but the entire patient, the entire system. And that includes where are they living, how are they getting food, how are they getting transportation? And these are some of the things that we work on in the disability community so that we can live in the community like we do. And be able to have successful lives. So it's so great to be with all of you here today. Again, my name is Dr. Kimberly Jackson, she, her pronouns. I am a white woman wearing purple framed glasses with short hair. I have a white and blue neck brace on and a blue flower shirt on. And I'm grateful to be on the panel and with all of you here today, even though we're maybe miles apart. So thank you so much. And I'd be happy to answer any questions you might have.
Thank you so much, Dr. Jackson. Wonderful hearing your story. I mean, I can't imagine roller coaster that it's been and how much your experience in having the multiple illnesses and conditions that you have has impacted you, plus with you being a physician at the same time. Your perspective is really, really unique and valuable. So thank you so much for being here today. I think what we'll do then is we will move on to our next panelist, and then we'll see you again later on when we get you onto the Q&A. So if we can move and bring Vesper Moore on the stage. Vesper Moore is an Indigenous activist and leader deeply involved in promoting mental health and disability rights through activism, leadership, organizing, and public speaking and education. Vesper focuses on cultivating social movements and enhancing public awareness to foster lasting social change. They've actively contributed to the establishment of mental health organizations worldwide and have fought to uplift civil rights to the United States. Vesper has brought perspectives of people with mental health challenges and disabilities to national and international spaces with their advocacy. Vesper works with Vesper works with both the United States government and the United Nations in shaping strategies around trauma, intersectionality, and disability rights. They have been at the forefront of legislative reform to shift the societal paradigm surrounding mental health. Vesper, it's so good to have you here. Tell us a little bit more about yourself.
It's great to be here. Hello, everyone. I'm Vesper Moore. I'm a brown, mixed race person, Indigenous person specifically. I have black hair up in a top bun. I have a black beard, and I have a white background, primarily with a gourd mask behind me and a gourd rattle. I'm so glad to be here with you all today. I think something that is so important when we're talking about access to universal healthcare, and a lot of these means, is considering what we are accessing and what those services look like. If persons with disabilities were included in the inception, the creation, and the design of a lot of these resources. And I think that that's something at the center of the work that I do every day, to the point of what our previous panelist was speaking about, it's that idea of, are we included throughout the process? I think another means as well is access to specialty care is I think an important consideration. For myself as an Indigenous person, I also consider that, when we're talking about intersectionality and access to alternative healing practices within our community, and also giving back to tribal economies in that way. I think in my own story as an autistic person and as a person living with a mental health condition, it's been so important to have access to resources and really those critical questions. I think along with that, peer support and peer-run resources come to mind as resources in the disability community, and that I've seen have been really critical for the mental health community. I think when we talk about peer support resources, they're not covered by every means of private healthcare and public healthcare. So I think when we're talking about access, this is absolutely critical. And the reason why is that you want someone that might understand what it feels like to experience and go through what you are going through in that moment in time, whether if that's related to your disability, recent trauma, or an event that might have happened in your life. It's really important to have someone who knows what it's like to sit there with you in that moment. And then you have to ensure that you're able to access it as well. I think a great resource that I've been promoting are peer-run respites. The organization that I work for, Kiva Centers, we have 3 peer-run respites. And these peer-run respites are critical resources for people who might be coming out of a mental health acute unit, might be coming out of a lot of these spaces, and might need a home-like environment that is run by people who know what it's like to be on a mental health acute unit and support them for up to 5 to 7 days. I think resources like that are so critical, and they need to be, accessed far and wide. But I also think when we're talking about single payer healthcare, it's important to consider, coverage in terms of again, specialty services, but also mobility devices and any other types of supports that people need. In my own story, I'm someone who also lives with a heart condition. I went to the emergency room with my current health plan a couple of years ago, and I was charged $2,000. And I know in terms of affordability for many folks in the United States, people with disabilities or otherwise, that affordability is something huge in terms of consideration. We are often paid in such a way that is sub minimum wage, and I think that has to change. When we're asking, and especially considering different communities, especially Black and Brown Indigenous communities, who are often, moving through the world with a disability and being treated with such violence and contemption, sometimes by society and systems. I think that that's so important, and the reason being is that particularly when we talk about mental health challenges and mental health conditions, where we are at the intersection of ableism, where we are viewed as disposable, but also being perceived as dangerous, often without a lot of reason. And instead, we could have resources that meet people where they are in moments of distress and really aim to understand what they're going through. So I think on top of a universal healthcare system, we're also talking about comprehensive means to meet people at every level, to assure that they are not mistreated horribly by a system. Thank you.
Thank you so much for sharing. You've I mean, that's a really valuable perspective that you have coming from an Indigenous community. It's specifically on the topic of single payer healthcare. What do you think policy initiative like that, how would that affect your community specifically? Like, what would that improve? Are there any areas with the way it's envisioned right now that you think could be tweaked to accommodate your background more?
Absolutely. I mean, I can say for tribal communities, Indian health centers, um, Indigenous health centers often offer separate healthcare and well, still access to the same healthcare, but different services. And often when people are off of the reservation, having access to the same type of community resources can be a challenge. So I think for our community, it's considerations for urban Indigenous people who might be off of reservation, living in urban environments for whatever reason. There are so many of us who have family members who are on tribal land, but we live in urban environments, usually because of the struggle with blood quantum and blood quantum requirements. So I think in terms of access to the same services and access to the same community healthcare is a critical issue.
Really an equitable approach that makes sure everybody gets covered, really. So here is, there's so much to think about that you brought here today. We have you close to time. Do you have any closing remarks before we move on to our next panelist and enter into our Q&A session, just to keep things moving along?
Absolutely. I would say in summary, that we're looking at access kind of across communities. I do want to emphasize the role of being critical about what we access and what it looks like, and ensuring that it is truly for us. I can't emphasize that enough. I see large behavioral health organizations go into communities and decide what a lot of these resources could look like without asking the local community. So that's an important consideration. So on top of it being accessible, ensuring what is put in place truly serves the community.
Thank you so much. Really appreciate your thoughts and look forward to hearing more of them in just a few minutes. We're going to move on. We have our last panelist here, Michael Neal. Michael Neal is a Denver, Colorado native with spina bifida and upper motor neuron dysfunction. In graduate school at the University of Denver, he joined the Center of Rights Development from 2006 to 2007 and the DU Task Force on Modern Slavery from 2007 to 2008. His academic work focused on John Rawls and the intersection of theories in democracy and disability politics and citizenship. Upon his dissertation completion in 2013, he became a part-time ADA compliance investigator for the Civil Rights Enforcement and Education Center. From 2015 to 2016, Michael was appointed by the governor to Disability Benefits Support Contract Committee, which became the Disability Funding Council in 2016, which he has chaired since late 2017. He joined the Colorado Cross Disability Coalition in 2015 as a legislative liaison. Throughout his life, Michael has been a consumer of both Medicaid and Medicare, which demonstrated the benefits of not having to worry about whether his frequent doctor's visits or 18 surgeries would be covered. Through those experiences, Michael became a great supporter of single-payer healthcare. Thank you so much for being here, Michael. First question, I just want to confirm whether I pronounced the first disability that you listed right. Is it spina bifida? Could you pronounce that for me? I'm afraid that I...
That's okay, Alex. So I always pronounce it spina bifida, and upper motor neuron dysfunction. You guys would probably know better as cerebral palsy, but cerebral palsy implies a congenital origin that was not the case for me. So I use the grab bag term instead.
Well, thank you for illuminating on that. Just wanted to make sure I was being respectful there. I said that like, I don't think that's quite right. Well, tell me a bit more about yourself.
So, like it said, I am I'm a not quite so young man, wearing a blue gray shirt, white fellow with brown hair that you see, and I am here in Denver. I am the vice chair of Democrats with Disabilities for Colorado, and I am the also on the board of Progressive Democrats of Colorado. I am newly on the board of Colorado Foundation for Universal Healthcare, as well as the things that you described, Alex, through Colorado Cross Disability Coalition. And for me, I think the center of what's important about single payer for me and why it's important is, first of all, that I've been on single payer or something very similar through both Medicaid and Medicare, but that it is very, very hard, even in the Medicaid and Medicare systems, to make enough money to even have a job that's making a job worthwhile when you either can't have the assets through the asset testing that Medicare and Medicaid have, but you also simultaneously have to pay for a personal care attendant. So the last piece of that being the personal care attendant, it's crucial for me that we have a long-term services and supports option for those of us with disabilities within the context of a single payer health system. So I have been an advocate for single payer for many, many years, though not uncritically, because we really need to pay attention to what is in that single payer bucket in terms of who does need secondary assistance from another person and how that is paid for and what is covered under a single payer plan in terms of long-term services and supports. So that is sort of my focus on this, is to keep us on the ball about long-term services and supports. The other thing is that I think is important to sort of note when we're talking about single payer is that it should, by virtue of the fact that we would be divorcing ourselves from certain Medicaid rules, it should be able to allow us with disabilities to actually gain meaningful employment. Right now, there's no employer-based system that I know of that would take on paying for a personal care assistant. And because the pool of risk is just so incredibly high, it would need to be spread out. And the only way to spread it out is to really have a single pool with single payer with everyone involved. So that is something that I think is really crucial to me as well, is that I don't have to choose between my healthcare and getting employed.
Thank you for that. That's one of the questions that I have, one of the first things that came to mind. Is this something, like everything that you summed up, as far as having equitable access to care, especially in like multiple dimensions, that maybe the current single payer vision isn't entirely on board with? How far do you think we have to go to make sure that that is something that's fully embraced by everybody that supports single payer?
So I think it depends on what organization you're in and who you talk to. I don't get a lot of pushback, but I think that there is a certain utilitarian mindset of the greatest good for the greatest number of people. And that is, I mean, that it's not evil to want the greatest amount of healthcare for the greatest amount of people. That's certainly not something that we want to try to do away with, but there needs to be the recognition that we are expensive, and that just because we are expensive and just because we need assistance does not mean that we are not a valuable part of the equation, and that needs to be taken care of in some form or fashion. So that's something that I think that there's some concern among Colorado Foundation for Universal Healthcare. I think the majority of folks are with me in this. There are a couple of folks that I think that, like I said, rightfully want to see the cheapest system that we can stand up, because money isn't, money is not money is definitely an issue. It is not an issue, and we want to be able to run these programs in a cost-effective and efficient sort of way, but we can't dispose of folks who are expensive when we do it.
Of course, it makes me think of that one graphic that compares equality to equity. It's if you can't reach above the fence to begin with an equal foundation, then it's not meeting the needs. Some folks are just going to need more support than others, and that's perfectly okay. Making sure that the whole vision and policy would accommodate for needs, like how you put it, like more expensive, that should be something that without a question is provided for. That's just natural. There's no way of getting around it, not just for the disability community, but everybody's needs are different. And making sure that everybody is covered under that plan is, I think, top priority. I noticed and thought it was interesting that you said that you don't get a lot of pushback, but there's a utilitarian mindset, like trying to get something through as quickly as possible, which is interesting, because then you're not really taking people head on like there's a major conflict. There's a sort of wedding of philosophies that needs to take place here, so that everybody we're in more of a unified front, and we're seeing each other and understanding each other. Really appreciated you saying that. We have one quick question, if you don't mind just taking a couple moments. Let's see. Does Medicaid have an estate recovery provision? Sheila Golden asks, I'm thinking of California's Medi-Cal, which does. Is that anything that you can speak to real quick?
I would need to know what Sheila's referring to in terms of estate recovery. I do know that one of the things that Colorado and many states actually do have, which is something of a saving grace, is what is called the Medicaid buy-in, which allows for up to 450% of poverty, federal poverty line. You can make money, but unfortunately, even 450% of FPL is wonderful for one person's income. I think most of us could probably get through on that, but what we can't get through on is an income of 450% FPL for two people, and I mean for two people who are who are a person and their caretaker, let alone, if people are married, have children. I'm a single guy with no kids, but that's still another person, because I've got to pay for my attendant, and I've got to pay them well, because this group of folks that we are gathered here today to address are, I think, interested in many different frames of justice. And so we know that our attendant care people, just like our therapists and everybody else, deserve living wages and deserve all of the things that we can't always provide them. And so we need to figure out a way in which our single payer system allows for all of that, and allows for the dignity not only of the person being taking care of and that has a disability, but also their care team and their care people.
What we can do now is bring all of the panelists to the front. I would like to open up the floor to questions from the audience, and we'll do that for about 30 minutes. So we can take that via comments. If you'd like to ask a question out loud, we can unmute you, and if you could keep your question statement to about a minute to allow the panelists to appropriately address that question. 30 seconds to a minute, I'd really appreciate that then.
I know that there's a shortage of home healthcare workers. Because I know people who have had very, a difficult time finding good people. And it's not necessarily something that could be directly addressed by single payer, but there are other issues that, come up in terms of how people are paid, maybe providing free education for healthcare workers. And also in immigration issues. I mean, I know many healthcare workers that I've met are here from other countries. Yet we're trying to block immigration. So do you have any thoughts on that, or how that issue might be addressed?
So I think there's many ways to skin that cat. I think that one is some sort of a housing stipend. I think that there's also some training monies that can be given. I think that there's also some, if you're able to, and this will vary on terms of people's acuity, but if you're able to take someone that is, just coming out of college as your personal care attendant, I think that it would be a very interesting proposal to try to knock off some tuition for that individual to do that work and make it more more of an inducement. I have been 4 years without almost 4 years without a personal care assistant of my own because of the pandemic and because of the dislocation and public health emergencies ending and all of those chaotic things that we are all living through. So I think that there's a number of things that can be done, but yeah, right now I'm feeling the pinch incredibly badly, that there's no one to find.
And just to jump on that a little bit too, I mean, one of the things that we did in Colorado through the pandemic is make sure that the workers that we have, the program in Colorado is called Consumer Directed Attendant Support Services, and that's the program under Medicaid that we use to help pay for our attendants. And so with that, we managed to get past sick pay for our attendants. And so now I think it's a total of maybe 40 hours a year that they can accrue in sick pay. And so if they have a doctor's appointment, if they're not feeling well, they can use that so that they cover their income. Because I mean, as Michael was saying, we try to pay our attendants as well as we can because we don't get a huge amount of money in our budgets to pay them. And even with that, it can be hard to find somebody, especially if you don't have exactly 40 hours a week full-time position. Or you need random hours at different points during the day. And so really talking with people with disabilities when thinking about designing systems like that. And okay, this sounds great, but how do we really make this work out? And how do we make sure that people have attendance? It's important to ask. And the other flip side of that though, is the reason that there aren't more structures for finding attendance is that whole idea of we aren't getting pushed in one direction or in one box and we have the freedom to hire whoever we want. And so, I mean, there are arguments both ways about that, but unfortunately, it is getting hard to hire people. I've gone years without having enough support. I'm grateful right now that I happen to have 2 attendants that work for me and things are going so much better. And when I don't have that, I can't do the work that I do. I can't be here speaking with you guys and I can't live my life. And that's all I'm asking to do. And not only that, I'm giving 2 people 40-hour-a-week full-time jobs, helping me out. And it's a huge help. And so, yeah, I mean, I think to answer the question, the shortages across the board, a lot of it has to do with funding. People don't want to put the money behind it and think, oh, if we cut funding, then it's going to cost less. but we're so siloed looking at healthcare because we've got Medicaid and we've got attendant care, we've got hospital care, and we've got clinical medicine. And then working and disability are separate from all of that, but they're all part ultimately of the same system. And so if we think about spending just in each of these boxes, we can't look at what's the overall effect on the system and on the country. So I don't know if that addresses the question so much. I mean, unfortunately, it's like everything. There are no quick, easy answers, but we really do need to start addressing it, because the scary thing is we're going to be 10,000 doctors short. I think 10, it might even be 100,000, I can't remember now, but within the next 10 years. We're seeing that, unfortunately, physician assistants and nurse practitioners are great for providing primary care, but they're not the answer to the shortage. We still need doctors, and we still need to have that care as well. So worker inflation, healthcare worker inflation comes from that. And there are just so many issues we could talk for hours and hours about. But I hope that answers your question a little bit about the shortages.
Yeah, thank you. I think you're right. It's important to have more integration in all these different areas because everything is interlaps and overlaps. I mean, and it's yeah. Thank you. I appreciate it. Thanks, Michael and Kim.
Thanks so much, Pat. The next person that we have up to ask a question, Carla Sand, I'm going to ask you to unmute, and then if you can keep your question in about 30 seconds.
This is Carla Sand in Minnesota, and I'm a member of Healthcare for All Minnesotans in the Twin Cities. But I don't have a real quick question, but I'll explain to you why I'm coming on. Is because I am a senior and I have lost my hearing at a late age. That is a big difference between being deaf as a younger person and then being used to the situation. So we have a large senior population in the country right now, and I think this needs to be given some kind of attention. But I was pleased to have, I think all the speakers described themselves. You do not know how helpful that is. But also I was saddened to hear them say that possibly persons with disabilities are disposable. And that is, seniors as well sometimes feel disposable. So I just want to make sure we include seniors and deaf and blind persons in this world of disability. That's all I have. Thank you.
Thank you so much. No, appreciate your thoughts. It's wonderful.
I just would love to comment on that quickly.
Oh, for sure.
Yeah, no, I really appreciate your remarks and your statements right now. I think part of the difficulty I've seen in trying to bridge that gap between working with the aging community, seniors community, and the disability community is that word disability, because all of us, people with disabilities or without, are afraid of losing function and then becoming dependent on services and needing to be in a facility of some sort and living in a facility of some sort. And so that disability word is very triggering, I think, to many people in those circles that aren't used to using that term. But ultimately, it's losing that function. It's not being able to access the world the same way that other people do. That starts to be where those parallels happen. And so I don't know what word to use other than disability to maybe help bridge that gap. But I see so many parallels between both groups. And I think if we can work together too, we have much more of a power base to really start making the changes that we need to make in the world. So thanks so much for your comments. I really appreciate that.
And I'd also like to add too that there's so many parallels when we talk about the aging in place movement and universal design. And I think that there's a lot in terms of the disability movement in collaboration with ideas of aging in place. So I do think our struggles are inherently interlinked, and I think that that's just such an important point. So thank you.
Okay. None of the panelists have anything else to add. I have it's like Pamela McAfee. If you could go ahead and unmute.
Yes, I don't know if this was addressed. I don't remember picking it up, but is there anything being done to try to stop the slow moving into private insurance taking over our socialized medicine, for lack of a better word, with these advantage plans, and the states letting private insurance manage Medicaid and Medicare? Nope.
Well, I mean, there are, I know there's a bill in, or was a bill in the California legislature that was asking, or I don't know if it was more like a statement that they were going to, they didn't want to support this privatization of Medicare. I'm sorry, I don't know a huge amount about it, but there are, I know there are a number of groups fighting the privatization of Medicare, and you can probably find those. I can probably find those groups somewhere, but it is a really important issue because it's just, and there's people advocating, you know, Biden to not, because I don't think he, when Trump signed the ACO REACH, I don't think Biden has taken advantage of that, his position to get rid of that. So anyway, sorry, I'm not being super clear about it, but there are efforts. Maybe other
And
people.
I just, oh, sorry.
Oh, no, go ahead. Sorry.
I've worked on this a little bit in Colorado. I haven't done a ton of work around it though. And it's hard because the Medicaid Advantage plans, they try to offer other benefits that aren't traditional Medicare, such as dental benefits, vision benefits, things like that look really good. And they tailor those policies mostly towards the senior population, people who are on Medicare because of age. And so unfortunately, most of them are not good for people with disabilities because they're not really geared for that. They don't look at some of our needs in terms of DME, durable medical equipment, and those sorts of things. And so we've been fortunate enough that we still have traditional Medicare. And in Colorado, there's been some move to try to do that with Medicaid in some areas too. But there's still also traditional Medicaid available. And so I'm both traditional Medicare and Medicaid because of that, because I don't know if the Advantage plans are going to cover the services. But the nice thing, at least about Medicare and Medicaid, is it might be thousands of pages, but I can wade through a manual somewhere and find out exactly what I need to qualify for whatever benefit or service it is. And so to speak to the question of stopping that whole practice, I think it goes back to the rationing of care and healthcare as an industry and an industrial complex. And like insurance overhead is generally around 20 to 25%. Medicaid, at least in Colorado, our overhead is 3%. And so there are a lot of inefficiencies too within private care, but it's trying to figure out how can we provide the most services with the least amount of money. And so I think being transparent, being mindful of that, and being intentional with that. I don't know if stopping it is ever going to happen, but at least then we can make sure that traditional Medicare is still available and that it's transparent. Look, this plan's great if you need these services, but if you have a disability or disabilities and you need these services, it might not be as good. At least then you can see and make those changes. But if those are the only plans available in traditional Medicare and Medicaid or not, that's when there start to really be problems, at least for people with disabilities. So I don't know if that really answers your question, but that's my experience with it here in Colorado, at least.
If I could just jump in here, we have David Loud. Can you just maybe add a little bit to that? David is up in Seattle, active with Puget Sound Advocates for Retirement Action. And they're in the middle of the fight against the privatization of Medicare. Maybe just even give people resources so we don't get stuck too much on the question, but at least give people some more guidance as to the danger that's coming after the predatory efforts to destroy Medicare, which within about 5 years, as I understand it, is going to disappear. Traditional Medicare. David, can you unmute? Yeah.
Yes, thank you. There is a national campaign that is gathering steam. My organization in Washington State, Puget Sound Advocates for Retirement Action, is helping to lead that. And the strategy that we have settled on is what we're calling level the playing field between Medicare Advantage and traditional Medicare. We know that most of the people who wind up in Medicare Advantage do so because it's so much more affordable at the beginning because of the subsidies that are given to the private plans by Medicare. And so we know that it's not practical to say, let's get rid of Medicare Advantage, because a lot of people on it because that's what they can afford. So what we are advocating is that the Center for Medicare and Medicaid Services enhance the benefits of traditional Medicare to include hearing, vision, dental, and so forth that the private plans claim to have, although they don't necessarily deliver it very well, and to reduce the out-of-pocket of the traditional Medicare beneficiaries, so they're no longer have to buy a Medigap plan to cover the 20% that is not covered by Medicare, and to finance all of that by cracking down on fraud and abuse. And get this, the Physicians for National Health program has done a deep study recently, just in the late last year, they published it, which found that every year, 80 to 140 billion dollars are paid to the private Medicare Advantage plans in the form of overpayments. And so what I'm going to stick in the chat here is notice of a very fine webinar that we're putting on April 2nd that everybody's welcome to at 5 p.m. Pacific time. And you'll see there's a bunch of panelists there talking about this whole issue of leveling the playing field and the dangers that privatization posed to Medicare as Chuck said, it's only a few years before they'll gobble the whole damn thing up if we don't stop it. President Biden, by the way, in December, in a presidential comment, a formal comment, actually referred to leveling the playing field. He didn't propose to do anything about it, but he called it out as an issue. And so what we're trying to do is put pressure on the Biden administration to come forward with concrete steps to level the playing field so that people will have a real choice, and they know that they can afford to go into traditional Medicare, which has much more reliability in the long haul as a place where people can get what they need. Although obviously right now it's full of holes, and that's what we're trying to fill those holes with additional benefits. I just want to say I deeply appreciate the presentations we've had so far, because it really highlights something that in the single payer movement, a lot of people still are not well attuned to, and that is, what about folks with special needs? So anyway, I'm going to put that in the chat. Thank you, Chuck, for calling it out.
Yep, you bet. Thanks, Alex and David.
We have a question from Corinne Fragoni. Corinne, if you could unmute and go ahead and ask.
Thank you. Actually, it's a statement. Thank you for bringing this up there's a bill that Pramila Jayapal has, and Dingell as well, 3421. I advise everybody to look at it. And they have brought up single payer every year, and it has a whole section on long-term care services and keeping people in the home. And truly, as much as we're fighting against the privatization of Medicare, the only solution, and people should think about this, is a single payer healthcare system that covers everyone, takes out the profit motive, and there's certainly, as the longer we wait, the harder it gets, because private equity is taking over, and it's going to get more and more expensive to try to deal with how do we buy these companies out, whatever, it's beyond my pay scale for sure. But definitely look at 3421 as a national healthcare system, and things that Pisara are doing is terrific, because there's steps to get us there, and we have to look at what steps get us closer to a single payer system for everyone. And certainly leveling the playing field is one of them, but we need to go for the whole enchilada.
I have a question from Donna Smith. The issue Dr. Jackson brought up about discharge to unsafe or unhealthy situations is a massive one for those of us with disabilities. How do we get this system to recognize that disabled people who end up returning to predictable problems after too early discharge is more expensive in every way than listening to the patient and ensuring a safe and healthy environment to be discharged to?
This is an issue that I've been working on with the steering committee with the Link Center. and trying to figure out the answer to that question. And it's not easy. And I mean, I think Michael and I have been talking a little bit about the program that we have in Colorado, CDOTS, for attendant care. But that it's offered through Medicaid, but it's not necessarily completely a health benefit in terms of it's not paying a doctor for service and any of that. But it's even more important than any of those other services, because without that, I would not be living in the community. I'd be dead. I mean, with my complications and everything I've got going on with me, I'd last maybe a month in a nursing home before infection or something else would get me. And so that's not even an option for me. And so I think looking at programs like CDOTS with attendant care to help people out so that we can get them to traditional community settings, but with the support they need to live there successfully. And really too, looking when we're discharging people, that we're not just discharging them to a homeless shelter, for example. I mean, I don't know how we can do that. I mean, I understand it because you can't just keep them in the hospital forever, but why is it that we have no place to send people? And so, I mean, part of that is the whole mental health world and not really, I mean, not being sufficiently funded, not having the right services, not having the right, not having enough group homes for people. The group homes that exist out there, there are often abuse and theft and other problems going on in the group homes. But again, it's all seen as separate from medical and from healthcare. And one of the members of the steering committee mentioned, for example, she was in a program for a while, inpatient, and it was scheduled, and she's autistic, and we tend to do better when we have a schedule. You know exactly what's going on when. Nutrition was available, she was getting the right foods, she was doing so much better, and then sent her home, and she didn't know how to do any of this for herself. She didn't have that training, she didn't have that support. And it was just sort of like, okay, go to it. But I mean, all of those things, especially the nutrition component, can really help with overall health and overall healthcare. And so I think, I mean, to answer your question, how do we get people out of the hospitals back into the community and into appropriate community settings, is really looking at that as part of this healthcare monstrosity that we have, this giant healthcare system. But I mean, discharge options as being a really important part of hospital care. Because again, if we spend all this money on acute care and treatment in the hospital, and we send them back to the situation that got them there in the first place, they're going to come back and we're going to spend that money again. And there's that, and there's really it's hard to have accountability around that because of the siloed systems that we have. And so what do we do? I guess to get back to it. And my only thought with looking at this more and more is it's really got to be a community solution. How do we get people out of the hospital, especially people with developmental and intellectual disabilities and mental illness? It's a community approach. I don't know what your community looks like. I don't know what services are available. I don't know what group homes are available. And so it's really hard to give specific recommendations. What can you do? But I think in Denver and in Colorado, I'm seeing more and more people like, we need to fix this. What can I do? And so we now have community health, mental health workers that can respond to emergencies instead of police and law enforcement, so that people can be treated properly. But it's community driven. It's someone in the community saying, we need to do this. And so I think if we're going to improve the community settings for people with disabilities, for people with intellectual and developmental disabilities, mental illness, and all of that, it really needs to be a kind of grassroots community, both like patient community, but local community approach, and people getting together and saying, okay, we want to figure this out. We want to make this work. What do we need to do? And what are components in our community that we could be doing better? So I don't know if that helps a lot, but I mean, I really think that's what we need to get back to, is that grassroots community approach to it, because the system's not working, and so many of us struggling so hard to get things to change, and it takes forever, but we need to get this fixed now. We don't have time to wait for the system. And the only way to do that really is kind of grassroots. So
I think that community aspect is really important. And I was wondering, Vesper, because you said you had respite facilities that you run from your organization, can you maybe explain a little bit more about how that's funded and I assume it's run by, or this model is run by people with disabilities?
Yes, it's run by people with disabilities, and so currently the way in which respites are funded throughout the country, they are all funded differently. Some are funded by town, states, some are receiving Medicaid, others. We are trying to build the conditions currently for Medicaid funding because we just opened our peer-run respites in 2021. They're relatively new. We actually started as kind of a pop-up respite at the height of the COVID-19 pandemic as a way for people to be able to quarantine while they were in crisis, but still have that support for 5 to 7 days. So it's been an interesting time, but I would say in terms of how our respite model functions, it's basically having mobile peer respite care. We go to people, we meet them in the community, we meet with them virtually, we meet with them over the phone, or they can come and stay at one of the 3 houses for 5 to 7 days. Again, it's 24/7 support, usually by certified peer specialists, is how we're operating it. But there are many different lived experience professions like community health workers in Colorado, like Kim was just talking about, and having those different responses. So we are also looking at peer specialists as a response, as an alternative to police for certain 911 calls. Yeah, there's a lot of different conversations. But yeah, in terms of Medicaid, Medicare coverage, and sustaining Medicare, I think more broadly, I'd like to see respite care more a part of that as well.
Yeah, thank you.
Hopefully we have about time enough for one more question. If I didn't get, like I said, we didn't get to anybody, feel free to shoot me a message in the chat. I'll share my email with you and I'll do my best to relay and get a question answered for you. Let's see, Malia Grover, if you want to unmute.
So I'm a white woman with brown hair and glasses and also a retired cardiologist. I'm a member of PNHP, which is Physician National Health Plan, which was already mentioned by David, where we have published and on the website is the Medicare Advantage document. We're doing a couple things. I'm in California, and we are the national organization is working on trying to educate everyone how terrible Medicare Advantage is and how much of the money is going to insurers and pharmaceuticals rather than into the healthcare delivery system. We also have the bill that passed in California was SB 770. We're asking for the Medicare waivers coming directly to California so we can decide how they get distributed. And finally, there is a bill that's being considered, AB 2200, which is universal health care. Unfortunately, will probably not pass because of the budget problems. And I'd like to second my colleagues, the Corinne's thing that we should all support, the Jayapal and the Sanders bill. They've thought a lot about this. Again, probably not going to pass. And also like to encourage you to join PNHP. I'll put the name in the chat. Thank you.
So we're pretty much at time for this Q&A segment. So thank you all one more time, just to remind everybody, if we didn't get to your question, just shoot it in the chat. I'll do my best to get an answer for you later on. Chuck, I think it's time to bring you on and move on to the next phase. And thank you all so much for your questions and to the panelists for offering their insight. I think it's engaging in a really important conversation here, and I hope that we can keep it going after the summit as well.
Okay. And as on cue, Representative Dingell has just arrived. This is terrific timing. I was just in response to a lot of questions people had. I started to type into the chat the single payer bills that we're working on. I only got to, so far as ROCONA, state-based universal health care, but if other folks could put links for HR 3421, which is the Jayapal Dingell bill, as well as Bernie's S1655, I believe it is. That's the Senate version. And then, as I mentioned at the very top, if you weren't here, we have the exciting news to break today that Senator Ed Markey will be introducing the State-Based Universal Healthcare Act on the Senate side in early April, to be followed by a hearing, the first hearing on this legislation up in Boston on April 3rd. So a lot is really happening, and we're all in this game to get to national single payer, Medicare for all. We just happen to think right now we have the possibility of moving it through the states. A number of states are taking terrific action, and we'd love for Rep. Dingell to jump on our Sabuca bill as well, Ro Khanna's HB 6270. With that said, let's bring up Alan Minsky, who will be doing the introduction for Representative Dingell. Alan, are you in the house?
I am. Can you hear me, Chuck?
Yeah, gotcha. Perfect. Wonderful. We are partners going back many years, Progressive Democrats of America and One Pair States. Progressive Democrats of America was in the House, were with us. Donna Smith, I think, is still with us here. Mike Fox. This precedes Alan's time, and his brilliant leadership over the last few years has been just really inspiring, truly, and helping us to get through the pandemic, all of those healthcare forums, those Sundays, and you've expanded out to bring all your other issues into the room, including disability rights and justice. And the biggest star we have in Congress is with us today. We're honored, and I'm going to have Alan bring Representative Dingell from Michigan up. But Alan, thank you so much for the work that you do with Progressive Democrats of America, our partnership with One Pair States, Social Security Works, and a raft of other groups that are working on getting these bills passed and making life so much better for the disability community as well as for all Americans and globally. So Alan, thank you so much for being with us.
Thank you so much, Chuck. And yes, Progressive Democrats of America is also going to do a push to support now the Khanna and Markey bills, the combine the two of them, really one bill. And thank you for your leadership, Chuck. And thank you for everybody who's been on the call. I'm Alan Minsky, Executive Director, Progressive Democrats of America in Los Angeles on Tongva land. And I have a bad head cold. So everybody, please bear with me. But let me say that really reminds me, of course, of one of the recent times where Representative Dingell was on a PDA call. I can't quite remember the occasion. I think it might have been around a previous threat of a government shutdown. And Representative Dingell joined us, and she had COVID and still joined us. And so I have a bad head cold, but again, it just goes to show the commitment to service that Representative Dingell just exhibits. And as Chuck referred to, she's one of the great champions of disability rights. In fact, she is currently the co-chair of the Bipartisan Disabilities Caucus. She represents the 6th District in Michigan, and which is out west of Detroit and extends to, well, Ann Arbor is sort of in the center of it, and in many respects, the center of the district. But of course, she's also Representative Jayapal's Medicare for All bill has Debbie Dingell as the really co-author, continuing an incredible tradition, one of really the great family traditions in the history of the United States government, because her husband, John Dingell, and the Dingell family has been an incredible advocate for the kind of healthcare system that we all need in this country. And she has continued that tradition. And it's always great to be joined by Debbie Dingell. And I did want to say one thing about the bill that she has introduced, or Pramila Jayapal too, because I saw in the chat, and this does happen, as Medicare services get chipped away at and are not what we want them to be, people should always remember that the bill that Representative Jayapal and Dingell have introduced is it's a very upgraded variation on Medicare, and a really, really fantastic piece of legislation. Always honored to be with you, Representative Dingell.
Thank you, Alan. It's hopefully everybody can hear me. I've just gotten off the plane and arrived in Michigan, having done the budget last night. So I was determined to get here. So I'm here, and it's good to see everybody and be with you. And thank you for inviting me to join you for this important conversation. I got to hear a little of the previous before I was on, and I think everybody on this call agrees that it's time the United States joined the rest of the industrialized world in guaranteeing healthcare as a right for every citizen, resident, person that lives in that country. And I guess I would just say to you, Alan talked a little about it, but this is something that I believe I am here and to do now. My father-in-law, John Dingell, was one of the authors of Social Security and introduced the first Medicare for All bill in the 1940s. When he died, John got elected to Congress and he kept up that fight. And because of John's father and John, we got Medicare in 1965, and he has never stopped fight. He never stopped fighting for it. We got CHIP, Children's Health Insurance, Obamacare. Today's, by the way, it's the anniversary of Obamacare. And I want to draw everybody's attention to the fact that Donald Trump still talks about taking the Affordable Care Bill away from people. And that is something that everybody should be willing to talk about, and talk about how this man, we're not where we need to be. I believe that when you're sick, you need to be able to go to the doctor and get the medicine you need and not think about whether you need the treatment. And I made a promise to my husband when he died that I would not stop fighting for this. And it is something that I get up every single day trying to figure out how we're going to do. And I work on a lot of other issues, but it's fitting. I didn't think about it until the second that this is the anniversary of affordable care. And we have a man running for president that wants to rip healthcare away from too many people. So yes, this is a passion of mine and I'm never going to stop. But we're talking today about people with disabilities as well. And I am co-chair of the Bipartisan Disabilities Caucus. I know that this is especially important to Americans living with disabilities, as you already face additional barriers in getting the care that you need and you deserve. A healthcare system that ties coverage to employment will always have patients vulnerable. And certainly during a pandemic, it made way too many people vulnerable. And in normal times, it's a significant issue as well. We watched millions of Americans lose their jobs and their healthcare coverage at a time when everyone needed it to be guaranteed coverage. I mean, this is when people were afraid to go to the doctor. People were afraid to go get tested. They couldn't afford being tested. It's one of the reasons we did so many things that we did. And we've seen a rise in preventable deaths during this time because people were reluctant to pursue the healthcare that they needed. And we saw corporations pad their bottom line at a time when thousands of Americans per day were dying of the coronavirus, not sick, dying of the coronavirus. And while others just couldn't get the urgent care or the treatment that they needed because we had a healthcare system that was completely overwhelmed. It's flat out wrong. And it's why I am fighting so hard for Medicare for all, because Medicare for all would put a stop to it. And I think, obviously this has been something I've been fighting for. I've been in Congress my 5th term. My family's been fighting for decades. But I think the pandemic helped show people why we need to fix this system. And we're not going to get it through a Republican House, but we should be talking about it during this presidential election. In this country, we spend twice as much per person compared to the countries with systems like Medicare for all. And we still have 26 million people without insurance. And what most people don't understand is we have worse outcomes than those that have Medicare for all, including life expectancy. And I chaired Michigan's Infant Mortality Commission in the 90s. Our numbers went down. Our infant mortality rates are increasing again. The only people that are benefiting and the people that don't want us to improve the system are the ones that are profiting while Americans struggle. We've been fighting as I said to you, we've been fighting this fight since the 1940s. I'm working on some, and we got to keep going. And so that's why I know everybody on this call is doing that. But we're working on many other pieces of legislation in the meantime to expand access to care for individuals with disabilities. This is another, but this is having been a caregiver to the man that I loved, who was one of the greatest men in the entire world. And I miss him every day. I introduced the Better Care, Better Jobs Act, the HCBS Access Act, expanding.
Representative Dingell from Michigan up. But Alan, thank you so much for the work that you do with Progressive Democrats of America, our partnership with One Pair States, Social Security Works, and a raft of other groups that are working on getting these bills passed and making life so much better for the disability community as well as for all Americans and globally. So Alan, thank you so much for being with us.
Thank you so much, Chuck. And yes, Progressive Democrats of America is also going to do a push to support now the Kana and Markey bills, the combine the two of them, really one bill. And thank you for your leadership, Chuck. And thank you for everybody who's been on the call. I'm Alan Minsky, Executive Director, Progressive Democrats of America in Los Angeles on Tongva land. And I have a bad head cold. So everybody, please bear with me. But let me say that really reminds me, of course, of one of the recent times where Representative Dingell was on the PDA call. I can't quite remember the occasion. I think it might have been around a previous threat of a government shutdown. And Representative Dingell joined us, and she had COVID and still joined us. And so I have a bad head cold, but again, it just goes to show the commitment to service that Representative Dingell just exhibits. And as Chuck referred to, she's one of the great champions of disability rights. In fact, she is currently the co-chair of the Bipartisan Disabilities Caucus. She represents the 6th District in Michigan, and which is out west of Detroit and extends to, well, Ann Arbor is sort of in the center of it, and in many respects the center of the district. But of course, she's also Representative Jayapal's Medicare for All bill has Debbie Dingell as the really co-author, continuing an incredible tradition, one of really the great family traditions in the history of the United States government, because her husband, John Dingell, and the Dingell family has been an incredible advocate for the kind of healthcare system that we all need in this country. And she has continued that tradition. And it's always great to be joined by Debbie Dingell. And I did want to say one thing about the bill that she has introduced, or Pramila Jayapal too, because I saw in the chat, and this does happen, as Medicare services get chipped away at and are not what we want them to be, people should always remember that the bill that Representative Jayapal and Dingell have introduced is it's a very upgraded variation on Medicare, and a really, really fantastic piece of legislation. Always honored to be with you, Representative Dingell.
Thank you, Alan. It's hopefully everybody can hear me. I've just gotten off the plane and arrived in Michigan, having done the budget last night. So I was determined to get here. So I'm here, and it's good to see everybody and be with you. And thank you for inviting me to join you for this important conversation. I got to hear a little of the previous before I was on, and I think everybody on this call agrees that it's time the United States joined the rest of the industrialized world in guaranteeing healthcare as a right for every citizen, resident, person that lives in that country. And I guess I would just say to you, Alan talked a little about it, but this is something that I believe I am here and to do now. My father-in-law, John Dingell, was one of the authors of Social Security and introduced the first Medicare for All bill in the 1940s. When he died, John got elected to Congress, and he kept up that fight. And because of John's father and John, we got Medicare in 1965, and he has never stopped fight. He never stopped fighting for it. We got CHIP, Children's Health Insurance, Obamacare. Today's, by the way, it's the anniversary of Obamacare. And I want to draw everybody's attention to the fact that Donald Trump still talks about taking the Affordable Care Bill away from people. And that is something that everybody should be willing to talk about, and talk about how this man, but we're not where we need to be. I believe that when you're sick, you need to be able to go to the doctor and get the medicine you need and not think about whether you need the treatment. And I made a promise to my husband when he died that I would not stop fighting for this. And it is something that I get up every single day trying to figure out how we're going to do. And I work on a lot of other issues, but it's fitting. I didn't think about it until the second that this is the anniversary of affordable care. And we have a man running for president that wants to rip healthcare away from too many people. So yes, this is a passion of mine and I'm never going to stop. But we're talking today about people with disabilities as well. And I am co-chair of the Bipartisan Disabilities Caucus. I know that this is especially important to Americans living with disabilities, as you already face additional barriers in getting the care that you need and you deserve. A healthcare system that ties coverage to employment will always have patients vulnerable. And certainly during a pandemic, it made way too many people vulnerable. And in normal times, it's a significant issue as well. We watched millions of Americans lose their jobs and their health care coverage at a time when everyone needed it to be guaranteed coverage. I mean, this is when people were afraid to go to the doctor. People were afraid to go get tested. They couldn't afford being tested. It's one of the reasons we did so many things that we did. And we've seen a rise in preventable deaths during this time because people were reluctant to pursue the healthcare that they needed. And we saw corporations pad their bottom line at a time when thousands of Americans per day were dying of the coronavirus, not sick, dying of the coronavirus. And while others just couldn't get the urgent care or the treatment that they needed because we had a healthcare system that was completely overwhelmed. It's flat out wrong. And it's why I am fighting so hard for Medicare for all, because Medicare for all would put a stop to it. And I think, obviously this has been something I've been fighting for. I've been in Congress my 5th term. My family's been fighting for decades. But I think the pandemic helped show people why we need to fix this system. And we're not going to get it through a Republican House, but we should be talking about it during this presidential election. In this country, we spend twice as much per person compared to the countries with systems like Medicare for all. And we still have 26 million people without insurance. And what most people don't understand is we have worse outcomes than those that have Medicare for all, including life expectancy. And I chaired Michigan's Infant Mortality Commission in the 90s. Our numbers went down. Our infant mortality rates are increasing again. The only people that are benefiting and the people that don't want us to improve the system are the ones that are profiting while Americans struggle. We've been fighting, as I said to you, we've been fighting this fight since the 1940s. I'm working on some, and we got to keep going. And so that's why I know everybody on this call is doing that, but we're working on many other pieces of legislation in the meantime to expand access to care for individuals with disabilities. This is another, this is having been a caregiver to the man that I loved, who was one of the greatest men in the entire world. And I miss him every day. I introduced the Better Care, Better Jobs Act, the HCBS Access Act, expanding care in the Home Act, and the HCBS, which is the Home Care Bill Relief Act, to expand Medicaid coverage from home and community-based services and invest in our care workforce. A lot of people want to stay in their own home. They want to be in the setting that they need. They don't need the full-time care. We've got more than 1 million people on the waiting list right now. Our current system, Medicaid's the biggest payer of long-term care in the country. And we need it for those with some in the disability community, and the baby boomers are aging. And this is a real crisis for us. And right now, we have so many people that need help, they can't find it. One, we don't have people there are too many people that are working 2 or 3 jobs in caregiving and still living below the poverty line. Not enough people want to go into it. And the current Medicaid system is designed towards institutions. Institutions are more for formal settings like that. And we don't have enough beds. We don't have enough caregivers, and we don't have enough beds. This is probably one of the single biggest crises we have coming. The caregiving economy matters. All other work is possible if you're not worried about those that you love. Women aren't going back into the workforce because they can't afford or find childcare. But I remind everybody, long-term care is equally as important. And we've got many young people that are in that sandwich generation. This week, I also introduced the Advancing Access to Telehealth Act to make telehealth flexibilities that were, I actually did this bill with Liz Cheney, believe it or not, but we put telehealth in during the COVID-19 pandemic. During the pandemic, we put it in so that we need to make it permanent, because a lot of people, you need to be able to see the doctor. You need to be able to talk to the doctor. Transportation's a problem. Telehealth, and you can do it's always good to have the doctor hands-on, but telehealth can take care of a lot of issues. And there's so many developments in technology that you keep that hands-on, but it's easier for people to see the doctor. Because for too many Americans, having physically to go to the doctor can prevent a serious barrier to getting the care that they need. The bill would permanently remove the originating site and geographical limitations that were temporarily waived to the CARES Act during the pandemic. Before this waiver went into effect, Medicare beneficiaries who wanted to utilize telehealth services could only do so at a designated originating site, and only in the event of a physician shortage. This bill would also allow any physician who can currently bill for Medicare to be eligible for this waiver. That's really important. Many people have the same doctor. They need to be able to go to that doctor. They want to be able to see him regularly. It would also make permanent the telehealth coverage at the federal qualified health centers and rural health clinics, allowing rural providers the ability to serve patients remotely as well. And it removes restrictions that limit healthcare providers' ability to provide access to smart devices and the innovative digital technology that I was just talking about, where there's all kinds of, you can do EKGs digitally, asthma, there are a lot of sugar tests. There's just a lot right now that can be done that way. So doctors keep their finger on what's happening with your body, but you don't have those barriers. Allowing Medicare providers to remotely monitor and track their patients' health will improve the quality of life while reducing costly trips to the emergency room. So we've made a lot of progress. I'm not stopping. I could go on. I have a ton of issues, for the disability community. A bill I got out of a committee this week was the Charlotte Woodward transplant bill. Well, it's a bill. People in the disability community, Charlotte Woodward is a young woman who I've become very close to, who is Down syndrome, but had a heart transplant a decade ago. And people want to ban. Charlotte is so contentious. She's been at every markup. The hearing we had, the markups we had from subcommittee to full committee, and I'll put money. We're going to pass this bill in the House. It was passed out of committee in a bipartisan way. But people with disabilities should not be discriminated against in having access to any health care because they have a disability. So that's one of the healthcare is a basic human right for me, period. And I think prescriptions are too high. I hate pharmacy benefit managers, and healthcare is something that makes me tick every day and I fight for every day. So we've made progress, but we've got a lot of work to keep doing. And I promise you, I'm never going to stop. Healthcare is a basic human right. You need to be able to go to the doctor when you need to. You should be able to get your preventative services. And my friends, it's something I'm never going to stop fighting for. So with that, I will yield back.
Okay. All right. Thank you, Representative Dingell. Your work is awesome and inspiring. Thank you for lifting our lives every day in the fight. Really, really appreciate that. At this point, Pat, did you want to? You want me to facilitate at this point?
Sure.
How
I
do
mean, I think we can just take some questions. I
Yeah,
see
you can just
Michael has his hand up.
help
So
filter through questions, the chat and hands that go up. Probably better to do a hands raised, and if you could keep your comments or question very short so we can get through a stack, that would be absolutely terrific. So thank you. Michael, your hand is up. Michael?
Thank you. Hello, thank you. So I had a question, Representative Dingell. Are there any plans or any thoughts that you are aware of to decouple income, at least to a greater degree, from the acquiring of Medicare and Medicaid in terms of income and or asset limits? Because one of the biggest things that we have, I think as folks with disabilities, especially high functioning folks with disabilities, is that we've got to choose between our healthcare and getting a great job. I'm looking at being a state representative in my home state of Colorado. Would love to do that. Would love to be a contributing member and pay taxes. Would love to do all of those things that normal humans do, but lose my healthcare in doing it.
I think we've had lots of conversations about this. I mean, you're talking about for people in the disability community that you need the access to the Medicare benefits, but if you get a job, it puts you at a higher level. And then you wouldn't have, depend what the job was, whether you'd have health insurance as well. I've had many conversations about this with many people in a variety of different ways. And actually, this one technically goes through the Ways and Means Committee. I think you all need to keep raising that issue and show people why you need it, build the business case, put the human face on it. And as part of all of these discussions, keep raising it, because I have this discussion with many people, and there's, change takes time. Look, John Dingell's father introduced Medicare in the early 40s, and we got it, not Medicare, but universal health care, and we got it in 65. So we want you to be able to work and have a job. We've got to figure out, I do a lot of casework that frustrates me a great deal too. So I promise we're going to keep working on it. I'm not somebody that ever makes false promises. It's an issue discussed. It's not an easy one to move right now.
That makes sense. Thank you, Representative Dingell.
Mm-hmm.
Is there any natural legislative package or bill where that conversation, that issue should be slotted?
Well, I think, there's a lot of conversations now about some Republicans want to talk about either whether people should have access to Medicare if they've got a certain income level. There's discussions, quite frankly, about Social Security and should there be a cap on earnings, or should there are a lot of income, different perspectives. I mean, it's a very complicated. What I want to do is make sure that we are protecting the disability community at all times. And quite frankly, I may be very blunt, with Republicans in charge of the House and Republicans in the Senate having a large enough number to filibuster anything. This is a hard discussion, but create the case, get the dialogue started. I can put a Republican spin on this so that people, like, we want people to be contributing, contributing society and paying taxes. It's the healthcare. I mean, the challenges that keep them there, which is why Medicare for All would take care of this once and for all. But
yeah, it sounds like several committees of jurisdiction though. Let's see, bring up Jean Dorio. Can you unmute, Jean? And again, anybody else who has a question, even if it's in the chat, if you can come up to put your hand up. Let's see, ask you to unmute. Jean? Mike, can you help us here? You're muted as well. Jean? All right, let's jump over to Alicia, and then Jean will, when you come unmuted, we'll bring you up. Alicia Contreras from
Good morning. Can you hear me okay?
Did I pronounce that right, Alicia?
Yes. Can you
Okay.
hear me okay?
yes,
Yeah,
we can.
Perfect. Well, thank you so much. This is really, really important. I'm a wheelchair user. I've been an advocate in the disability movement internationally. And one thing that is really, really one of my passions is to be sure that people have access to the right wheelchairs. Because if we don't have access to the right wheelchair, it has actually an enormous impact on the cost of attendance. If Medicare limits us to we don't have access to a power chair if we have a way to get from our bed to the kitchen, which is a ridiculous impediment for people to get a power chair. And if I have a power chair to go out in the community, there are a lot of things that I can do without an aid. So I would like to see that actually, if everything is so slow about everything, just by breaking that barrier, so people who need a power chair can get a power chair, can reduce enormously the cost of aids that many people need. Thank you.
That's a good point. I'm going to work with people, the appropriate people, to help define what that is and do a letter to Medicare raising the issue.
I'm sorry, can I just add one more thing there?
Sure, go ahead.
The limitation right now is that you have to, if you can get to the kitchen.
Unaided, you can't get I know that.
Right,
but
and
I'm
then the
gonna try
$2,000 limit that prevents also people from getting actually the cushions that are needed. That is another thing. If I can prevent having a pressure sore because I have the right cushion, that's going to save a lot of money in expenses in the health system. But thank you.
Okay, thank you, Alicia. Thank you, Debbie. Let's see, Jean, you were unmuted. Now you're muted again. Not sure what's going on. Your question maybe in the chat. It looks like you're calling attention to HR 4040. I can't really tell. But for now, we're going to turn to Madeline Jacobs. Hey, Madeline. Question, comment, brief?
Hi, all. Yeah, thank you. Can you hear me?
Yeah, a little choppy, but keep going.
Okay. I was a rural family physician in Southern Colorado, and I'm working on the board of the Colorado Foundation for Universal Healthcare now. The reason I got into medicine in the first place was that I had a sister with a spinal cord injury. So I've been very active with the disabled community as well. So thank you for doing this presentation. Speaking of wheelchairs for my patients, I mean, I have horror stories trying to get wheelchairs for my patients when I was in practice. I had this man who got a power chair so he could get around outside, but he was told that he couldn't use it outside. He had to use it inside. I'm not going to start my video or you won't hear anything that I'm saying. So that's just, it's been a huge barrier all along. I mean, there are tons of barriers to avoid providing care for our patients. And that is why I'm a single payer advocate. But, you know, really, Debbie, it has been, I really appreciate the work you're doing, and I always love to see you. But just getting basic care for treatable disease and preventing people from dying unnecessarily is why I'm no longer practicing and why I'm doing this work.
Okay, thank you. Thank you, Madeline.
Important, thank you. It's very important.
Yeah, keep at it, absolutely. Let's see. Jean, your hand is still up. If you have a question, if you could drop it in the chat. I think there's something wrong with your audio. Michael Penn, your hand is up. Michael?
Hi.
Very brief question. Thank you.
Yes, hi, Congresswoman Debbie Dingell. Yes, just have a very quick question. Sorry. Yes. I know Medicare for All has been introduced several times in the House in the House of Congress and Senate, you know, regarding a hearing. What would it take to move beyond a hearing and get it into a vote?
We have to build a will. What you all are doing here is part of, you know, I thought COVID might be a catalyst, but we have to, and I mean, there were a number of things that got us, you know, you need to look at each step along the way. Somebody put in the chat, when did it, in the 40s, when did universal health care? It was actually Harry Truman. My father-in-law first introduced national health insurance system in 1933. So that, not to depress you all. But it was Harry Truman they all worked together to get Social Security. When we got a conscience and realized how many seniors who had worked their whole life were dying in poverty, couldn't eat, couldn't get health care. I mean, it was just a stain on this country. And that's how you got Social Security through. We got the Affordable Care Act because women were being denied health care because being a woman was a pre-existing condition. Insurance companies probably were canceling people's insurance if they got cancer. There were enough horrific things happen. And I don't know if you all remember the fight on the Affordable Care Act. My husband I've had my own career and my own. This is, you know, we each got to get elected and we're accountable to the people that elect us every 2 years. And I work hard for this every day, but this is also what motivates me to go to work every single day. But, you know, John Dingell had one of the very first ugly town halls. There were 3,000 people inspired by some of the real conservatives. I'm right out of Texas. And people came to that town hall meeting with guns. They were straight. It was horrific. Okay. And remember that they intimidated people. That Nancy Pelosi and her leadership, Obama, John Dingell was a key part of it. He's right. They wouldn't let him. They told the truth. We told people the truth. And we talked about why this mattered. And Donald Trump's trying to repeal it, but you won't find somebody in the House or Senate that want to repeal it now because so many more people are able to get access because of healthcare. We define what people can get preventative healthcare and not pay for it in terms of a number of what screenings there are, etc. We need to talk to people. We need to put the human face on those that can't get access. Another reason we're able, but it's still an issue for many companies, we're competing in a global marketplace. For the automobile companies, which is where I worked for 30 plus years, the cost of healthcare was more than steel was in an automobile. And we're competing in a global marketplace where other countries, industrialized countries, have healthcare as a guarantee. We need to put the human face on this. We never stop fighting, and we're going to get it done.
Thanks, Michael and Representative Dingell. Appreciate that. And I'll just tell you personally that I moved here to Washington, D.C. In September to advocate for Ro Khanna's state-based Universal Health Care Act and showing up every day on Capitol Hill. And I've got a couch here. Anybody wants to come to town and let's go talk to our representatives and senators. I think you're absolutely right. The in-person, there's no substitute for that. There's no substitute. So thank you so much. Mike Huntington and then Donna Smith. Mike?
and then I'm gonna have to go.
Okay, like a few minutes, okay. Gotcha. Mike? Nope. Donna? Unmute?
Yes, thank you. Thank you very much. And thank you, Representative Dingell. First of all, I want folks to know, because there was a lot of controversy over the Affordable Care Act among single payer organizations, but many of us, it saved my life. And it saved many lives, and it still is saving lives. So while it's not single payer and it's not what we're all working for, thank you to the Dingell family and to the legacy your husband and the courage he brought to this fight. It mattered to millions of us that we were able to get care. Right now, and I don't know how you answer a big issue like this, but many of us are on fixed incomes, many of us who are disabled, and inflation has been just outrageous. And yet we can't qualify for Medicaid, some of us, and because our benefits put us just barely above the line for being able to qualify for the help in Medicaid or other programs that we may really need. And the demand for those programs is outrageous right now. Even Meals on Wheels has a 1-year waiting list. So is there recognition in the House and Congress right now? How do we alleviate some of that for the disability community that I think feels that probably more intensely, and seniors as well, who feel that very intensely?
Well, I'm talking about it a lot because I know it's really true and I hear about it every day. I don't, the Republicans are in charge right now and they don't have it. They want to blame Democrats for inflation, which I actually would blame on Donald Trump and his administration, which started much of this. But I would really, there's nothing that moves people more than the human face, the true story, the real story. And that's what we got to start doing. People, go to people's town halls if you're able to. Writing, I look at my mail, not every member of Congress looks at their mail. Put something in, do an op-ed, talk about what's going on. Find a forum in your local community to uplift the issue, to call into a radio show. If you do something that gets going on social media, goes viral, or the media is playing it up, you get people's attention. And we need people to understand what a serious issue this is. That's how we start. That's how I've done it all my life. I started the National Women's Health Resource Center. I don't want to acknowledge how long ago, because women were being discriminated against in healthcare. Many different things. You create that coalition. And that's what you've got to do. Someone asked me about how often you do a town hall. I did 140 of them last year. Unfortunately, it's more of a challenge right now in this current environment that people are disrupting them. A lot of people are not doing town halls. I'm still trying to do them, and I'm still trying to go to as many forums as I can. But it's become, a lot of people are afraid to do town halls. I won't run away from it, but we got to get every member understanding what this challenge is.
Thank you so much.
And I will just convey our deep gratitude to you, Representative Dingell, for being with us today. I hope you'll have a chance to catch. We'll send around the recording of the earlier part of the meeting while you were traveling, and really very powerful panelists. We look for them to come up for just even a comment, just to put a bow on this today. But to see our work is as intersectional. For the fight for disability rights, the fight for housing, the fight for economic justice and climate and healthcare, all of these need to be bonded, right? We need to create these connections, and we call it in our world the 3 P's of strategy: people, politics, and policy. We've got to connect ourselves. We've got to build relationships. As you've said, it's got to be personal at every turn as much as possible. So any final comment you'd like to make, Representative Dingell?
I always love being with you. I thank you all for what you do. Don't stop fighting, because that's how you get it done. You never give up. You keep what your target goal is, and you keep going that way. So thank you. Thank you, everybody.
Thank you.
Thank you so much.
Thanks.